Kia ora and welcome to Know M.E. This is the vodcast series where guest speakers talk about pressing issues surrounding myalgic encephalomyelitis, chronic fatigue syndrome. Join researchers, clinicians, and patient advocates as we take a deep dive into the most recent evidence-based information so that you too can know ME. In today's episode, we will discuss myalgic encephalomyelitis and long COVID, covering classifications and symptomology. We're joined today by the two most well-known names in New Zealand in relation to ME CFS, Emeritus Professor Warren Tate and Dr. Rosamund Vallings. Professor Tate has been an academic and researcher at the University of Otago in Dunedin for 55 years. He is a Fellow of the Royal Society of New Zealand, a Fellow of the Alexander von Humboldt Foundation of Germany, and was an International Research Scholar of the Howard Hughes Medical Institute in the United States. As a discovery molecular biologist, Professor Tate co-discovered new rare mechanism of gene regulation utilized by HIV-1. He works on mammalian memory and Alzheimer's disease and the development of a potential therapeutic agent. Since 2012, Professor Tate has focused a research program on ME CFS with preclinical studies of New Zealand patients to understand its biological basis. Professor Tate approaches research on ME CFS through the dual lens of an affected family of over 30 years and a biomedical researcher. He has found molecular signatures for the illness supporting its biological basis and is now studying how close long COVID is in its molecular signatures to ME CFS. Dr. Rosamund Vallings has seen patients with ME CFS for the past 40 years and has been involved in writing management guidelines, lecturing, and research. She was awarded the MNZM in 2008 for services to ME CFS and the Nelson Gantz Outstanding Clinician Award in 2016 by IACFS. She has written 3 books for patients and is a co-author of the International Clinicians Primer. Kia ora and welcome, haere mai. Thank you both for being here today. Ros, as a GP with a long career diagnosing and treating ME CFS, how would you explain ME to a fellow health professional?
Well, I think most doctors understand the term post-viral syndrome, and that's the sort of thing that occurs, or illness that occurs following an infection such as glandular fever, but usually only lasting about 3 months. And I think I would usually then explain that ME CFS is rather like an ongoing post-viral syndrome that can last for far longer than 3 months, often many months or even years. And the symptoms tend to generally mimic the initial illness initially anyway, but the illness is characterized by extreme fatigue and inability to carry on usually with one's normal activities day to day.
Okay, and Warren, from a researcher's perspective, how would you describe ME CFS?
ME CFS, and I would add long COVID to this, they're complex syndromes that arise as the reaction of each susceptible affected individual to a major stressor. And a key question that arises from that is, why do some people get this condition as a result of the stress and most people don't? We now believe from our own ME CFS and long COVID quantitative survey studies and others that this is a combination of both nature, that means it's genetically inherited in variations in the DNA, and also it's can be nurture, that is to say environmental effects and that have arisen in the personal health history of the person who comes down with the disease. And that might be a previous viral infection which has hit them quite badly. Both of these then, singly or in combination, can make people susceptible to coming down to these events. What we've found in our own research, looking at individual patients, even with the same disease course and level of functional activity, that they have individual molecular changes in many of their metabolic pathways that actually give rise to their symptoms. And that makes it very difficult, I think, for both patients and clinicians alike to come up with a single therapeutic which will affect all patients equally. And it explains for me why, some promising therapies benefit some people, have no change in others, and yet others, their symptoms are made worse.
I just want to touch back on at the beginning of your answer, you mentioned stress. Now, a lot of people commonly think that means mental stress, anxiety, that kind of thing, but that's not what you're referring to, correct? It's physiological stress. We'll just talk a little bit about the terms. So we've got myalgic encephalomyelitis, which is the UK term, and then we have the chronic fatigue syndrome term that was coined by a working group for the CDC in the United States. So I just thought, Ros, would you like to talk a little bit about the foundation of the name ME for us?
Well, I think this illness has been around for a long time. It's nothing new. And, you can look back in history many years, certainly at least 2 centuries. But there were several epidemics in the early part of the 1900s, one 1934 in Los Angeles and another in 1946 in Iceland. And both of these illnesses, when we look back, were the same thing that we're talking about today. And then in 1955, there was quite a severe epidemic type of illness at the Royal Free Hospital in London, which affected a lot of the staff, doctors and nurses. And it was a flu-like illness initially, which gradually became more severe, and many patients had to be admitted to hospital. And it was generally thought to be a neurological type of illness with a viral component causing it. And the patients were suffering a lot with certainly fatigue, but also often a lot of neurological symptoms. And in one study I read, they even injected the serum into monkeys and found they developed a very similar viral type neurological illness. And the descriptive term used was myalgic encephalomyelitis, and that's the name that the so-called Royal Free disease became known as from then on, really, in the middle to late 50s. Then in about 1984, there were epidemics in Incline Village in the United States, and one, of course, Tapanui, New Zealand. But the United States people coined the term chronic fatigue syndrome because that was, again, very descriptive of what was happening. Everybody was very fatigued and remaining fatigued. So we ended up with the term ME/CFS, which survives to this day, really, and the two names refer to the same illness. In 1989, the first symposium for chronic fatigue syndrome, ME, was held in Cambridge in Britain, and as a result of that, the illness was classified soon after as a neurological illness. And I think that there has been discussion from then on to the present day as to what we really should be calling it. Is it appropriate to have two different names and so on? And every conference you go to, this is thrown around as what we should call it. And different names have been suggested, but the ME/CFS label seems to have stuck for the time being anyway.
The term chronic fatigue syndrome first was used in the medical literature in 1988 to describe an illness that seemed like chronic active Epstein-Barr syndrome, which I guess was one way in which ME/CFS was described then. And then it has been attributed to the US Centers for Disease Control because they actually defined this. And in their case definition, it was started with chronic fatigue syndrome, a working case definition. Of course, the patients in the United States have hated this name because it is felt that when they've been to see their clinicians, their illness hasn't been taken seriously. And the Institute of Medicine of the Academy of Sciences of the US picked this up in 2015 in their report and recommend against the use of just that name, and also recommended that ME/CFS should be recognised as a serious illness, and patients deserve better care and carers deserve better. And so this has been a turning point really on how ME/CFS has been regarded, certainly in North America. And I guess, you know, I think the turning point in terms of the use of the joint name that Ros referred to was a meeting as late as 2016 in Florida that Ros and I were both there, and there were rather tentative suggestions there that really we should settle on ME/CFS or CFS/ME, and both have been used. And subsequent to that meeting, it sort of stuck, and that's kind of where we are today.
Great, thank you. And of course, we know the World Health Organization classified ME as neurological in 1969, but recently they combined the two terms, so ME and CFS, as a post-viral syndrome in 2019. So do you both agree that these classifications are appropriate, or is there more work to be done in this area?
I mean, I would agree that the classification is appropriate, but not every case that one sees has a defined viral illness as an onset. Sometimes maybe there has been a viral illness, but it's been hidden away and under the guise of various other sets of symptoms. So it's not always a post-viral syndrome that you can pinpoint. There are a very large number of patients, particularly young people, do seem to start off with infectious mononucleosis, which is glandular fever, and that typically does often lead to a post-viral syndrome, even a short-term post-viral syndrome. This is just a prolongation in many patients.
Warren, did you want to add something?
Yes, I did.
Thank you.
I would say that, you know, when it was classified as a neurological disorder in 1969, the supporting evidence was still pretty weak. That was the best classification, but that has strengthened over time. I think we now know the core symptoms, you know, are all neurological symptoms. And for me, actually, it's a much better definition today than it was in 1969. In other words, calling it a neurological disorder. It also doesn't then get into the problems that Ros has raised, that, you know, 20% of the cases of ME/CFS are believed not to be caused by virus. And so by saying that it's a post-viral syndrome is kind of confusing to me. So I think there's more work to be done in response to your question. You know, we need to.
I would agree, definitely.
Absolutely. And that's one of the wonderful things that you're doing, Warren, obviously, is research into the biomedical aspects of the condition. So, but speaking of post-viral conditions, most people are familiar with the term long COVID. Warren, would you like to just speak a little bit about long COVID?
Yes. I mean, what we have to say is long COVID is unique among ME/CFS diseases because we've never had a pandemic like this. The outbreaks that Ros talked about earlier, you know, in Tapanui and Incline Village and whatever, were hundreds of cases. So we could call them boutique outbreaks with subsequent post-viral syndromes arising. Even SARS-1 in 2003, the world case numbers were only just over 8,000. And there were some, you know, few hundred cases of post-viral fatigue syndrome. So what's unique about long COVID is that it's arisen with many, many cases at the same time because of the 680 million cases of COVID in the pandemic. And so it's given us an opportunity actually to look at a whole lot of cases of a specific case example of an ME/CFS type illness And that's, I think, very helpful from a research and an understanding of the pathophysiology point of view. I will say, however, that what has been confusing is the World Health Organization suggested that diagnosis should be made at 3 months. And I well remember a lecture that Ros gave to a medical class and a graph she showed, which has stuck with me. That is to say, 50% of us recover from viral illnesses in 10 days to 2 weeks. Another 20 or 30% might take up to 2 months, and some take even longer. So by putting the long COVID diagnosis at 3 months and having it, because it's so much in the public and clinicians' eye, people getting diagnosed even earlier than that, we're really in this transitional phase where people still may be recovering from the disease. And that's caused a little bit of confusion, you know. I was even told before my med lecture this year not to tell students that people couldn't recover from long COVID, you know, in other words, that sort of confusion. So I think, you know, most people with ME/CFS have got their diagnosis even well after 6 months because the exclusion of other illnesses. And so we've really got the people that are having long-term illnesses. With long COVID, there's an indication that maybe up to half of people might be recovering within a year. And that might be that group that we're going to recover, but have extended effects from the viral infection. And I still think we will see a group of them which are truly ME/CFS-like, which will go on for a longer period of time. In fact, some people now are saying that long COVID might develop into ME/CFS, which is a rather quaint way of saying it, but you know, there's a reality in that as well.
Yeah, I mean, we have seen that there are a certain number who fit the diagnosis of ME as well. Ros, do you feel that long COVID and ME are the same condition, or at least very similar in what the damage is that is caused to bodily system, and therefore the symptoms that manifest?
Yes, I think, again, it's, as Warren said, a very similar story that we're hearing, and the outcome of the longer lasting symptoms tend to be very similar. The extreme fatigue, what the patients describe as brain fog, they can't think clearly, they're unable to work, they have a lot of other bodily symptoms. And I think we see this constellation of symptoms following many viral illnesses. Even after a really bad attack of flu, this can lead into the ME/CFS. So I don't think one has to specify that this particular virus is any different from many other viruses. It's the outcome that becomes very much the same illness.
You know, what struck me just in the last couple of weeks, I've had some students come to see me who have got long COVID. And one of the things they talk about is, you know, having to be in a darkened room, and they can't cope with television or music even, or stimulus, you know. So that kind of element that we know about ME/CFS, which is a hypersensitive of the senses, is certainly there in this long COVID student group that I'm seeing.
Yeah, and I think also, again, the core symptom of ME/CFS seems to be exercise intolerance, and we see that in long COVID too, that people who might well have been quite sporty prior to their illness suddenly find they can barely walk across the bedroom or get to the toilet. They are so exhausted by even the most minimal exertion.
Yeah, absolutely. And that is the defining characteristic, isn't it, of ME? And we're seeing it in long COVID patients as well, that post-exertional malaise. So what are some other symptoms, Ros, that if a patient was to present to a GP's clinic, either after a virus like Epstein-Barr or some other trigger, how would you expect them to present?
Well, I think fatigue is probably the core symptom, and difficulty in functioning normal way of life. They become exhausted in a very abnormal, rapid way. Most patients with this illness cannot sleep restoratively and refreshingly, so they may have been asleep for 14 hours, but they still wake up feeling completely exhausted. So sleep doesn't have the normal restorative, refreshing effect. Many patients do have quite a lot of problems with sore throat, glands up, those kind of typical, what we would call viral type symptoms. Patients often do have gastrointestinal problems, difficulty in tolerating certain foods, develop a lot of sensitivities to foods, and environmental issues such as smells and bright lights, things like that. They become very intolerant. A lot of patients do have problems with muscle pain as well as muscle fatigue. So muscles can become very tender to the touch, but there is no obvious actual inflammation that you can see. You know, muscles and skin even may become very sensitive, but it's not red or swollen or inflamed in any way. So the symptoms are there, but there's nothing very much in the way of physical signs that the doctor can see to make a diagnosis. It's not like you can feel glands up most of the time. There may be glands up in the beginning of the illness and they may recur from time to time, but they're not always up. And similarly, patients will describe a lot of headaches. And again, there are often no very obvious neurological signs to explain these things. So these patients need to be widely investigated to make sure that we're not missing anything. There's nothing else going on.
And that's what it is, isn't it? It's differential diagnosis, ruling out other conditions.
Yeah.
Because, and I know from a patient perspective, it can be very frustrating when blood tests come back normal because of how much they're experiencing. And then for the blood test to come out, well, everything's in normal range. So what's going on?
Yes.
It is very tricky. Warren, have you found in your research, can you give a little bit of explanation as to what is going on?
Yes. Can I lead on from what you just said? Because a typical blood screen, of course, you know, you're looking at a small number of molecules really in the body, which are very good indicators normally of disease. And in this case, they miss. And that says, well, there's many other thousands and millions of molecules in the body which we're not kind of looking at. So what I've found in the research is an indication of inflammation, in other words, molecules and pathways which indicate that inflammation is enhanced. See evidence of immune dysfunction, that is to say, immune cell proteins in abnormal amounts, deficiencies in energy production, some evidence of neuro effects on neurotransmitter release that could relate to the neurological symptoms. And one sort of major thing is the changes in the control of expression of all of our genes, which is normally tightly regulated in healthy people, is all over the place in ME/CFS. And that's like, there are light switches which are carefully regulated as on and off in the DNA or dimmed. And it's as though someone's run amok in the DNA and just turn switches on and off randomly and whatever. And so there's what we call dysfunction, what I call in molecular homeostasis, just the same as we know there is in physiological homeostasis, you know, where many of the body physiological systems aren't controlled with the same degree of tightness, like blood pressure and heart rate and temperature and blood sugar, for example. So there's that, and the evidence of a dysautonomia, we're seeing that at the molecular level as well.
Yeah, and so just if we can just touch on that, Ros, how does that manifest in the body, the dysautonomia?
Yeah, the dysautonomia is very characteristic of this illness, and it's due to abnormalities in the way the body maintains blood pressure and heart rate and things like that. And you find that the typical symptoms patients will describe is that if they get up very suddenly, they feel quite woozy-headed or dizzy. If they're standing for any length of time in the hot sun, they may well begin to feel very faint and unwell, even pass out completely. You find that often there will be a tendency to feel quite confused mentally sometimes with standing or getting up suddenly. And typically these patients will have a low blood pressure, which becomes lower when they stand for any length of time. It's almost like the blood is dropping into the feet, and so the brain becomes oxygen deprived and they feel confused mentally and will often feel very faint, and some people do faint. Typically you get maybe a young person standing in line on a hot day at school outside, and suddenly they keel over.
And so there is a test that you can do in a GP clinic, or that the nurse perhaps could perform to test for that, the NASA test?
The NASA test is the so-called lean test, and it's a very simple test, really. The patient stands upright for a length of time, leaning slightly backwards against a wall, having perhaps been lying down beforehand, so there's a complete sort of 90 degree, I should say, change of position from where the head was flat to coming up, and then leaning back at a slight angle against the wall. There's a tendency to begin to feel very faint, and some patients do pass right out.
And that's just another toolkit for GPs,
It's a toolkit, yeah. It used to be diagnosed using, and still is really, using a tilt table where the patient lies flat on a table and then it's brought into an upright position, and so that change of posture creates the symptoms. But the tilt table is not very readily available for many people. It's not the sort of thing you'd find in average doctor's office, but certainly a lean test can be performed, and just gives the patient a sense of, yes, there is definitely something wrong with you, whereas so often they've been told, oh, all your tests are normal, therefore there's nothing wrong with you.
Yeah, exactly.
So the amazing thing really is what we manage to do as healthy people, like when we go from lying to standing up, there are immediate signals to make sure the blood flow to the brain is right, oxygen levels, so that's an amazing instant response. And so what we're seeing in ME/CFS people is probably not a huge difference, but it just affects the person, in such a profound way, but, a bit of amazing physiological change that normally.
And I think this is important for patients too, to be able to have something done that shows they have got some abnormality, because so many of the routine blood tests and things that they have done, they're told, oh, everything's normal, therefore there's nothing wrong with you. And that's been told to many, many patients who are obviously quite ill a lot of the time. And not a great many of them as yet would have access to the sort of tests that Warren is talking about, which shows some very real abnormalities in the immune system and the blood system generally. So the routine blood picture is almost always very normal in most of these patients.
And I think that's where some of the emphasis came about, thinking that it might be psychological then. If it looks from a blood test point of view normal, well, what else is it? Oh, it must be psychological. And that's erroneous thinking as far as I'm concerned. Would you agree, Ros?
Yeah, I think, this has been the story over many, many generations with this illness, that because nothing abnormal has been able to be shown up in the blood picture, it's assumed there's nothing wrong. But of course, what Warren is talking about is far in advance of all that, and we've got these tools becoming more readily available.
Absolutely. And Warren, we will touch on a little bit more about your research. I was just thinking, we were talking earlier about triggers. Obviously, with long COVID, there's one obvious trigger, the SARS virus. But with ME, we've talked that majority of the patients, the trigger is a virus, but there's about 20% that have other triggers. Do you want to talk a little bit about what those other triggers might be for a GP who's presented with a patient in their clinic?
Yes, I think we're getting, I mean, Ros obviously can comment on this too, but I think we're getting a better understanding now of what some of the major, stressors that can cause the illness, and things obviously like toxic agricultural chemicals. So people are working in the agricultural centre, and I first came across this, I think, when Ros and I gave a workshop in the Bay of Plenty, and people had come in from the rural areas, and I was amazed how many young people came up and talked to me that were suffering from an ME CFS like syndrome, when I thought, well, they're not in high density population areas, and you wouldn't think they'd be getting viral illnesses at the same rate. So something was triggering theirs, and that might have been exposure to toxic chemicals. But even things like some sort of trauma in one's life. It might be, a car accident or some damage, to the head or neck, can also be something which acts as a trigger so that ME/CFS can develop. Emotional stress, in my young woman's University of Otago study group, I've had 5 people who have got 5 different sort of sources. One, Lyme disease, as it being presumably a result of being in a Swedish forest where there are ticks, which, and she had ticks over her and presumably got bitten and ended up with Lyme disease. So that's a bacteria. So that's another kind of source. And another person who had a lot of childhood abuse, continual childhood abuse, and that just spiraled down into an ME/CFS syndrome.
And that's just a constant assault of high cortisol in the body, and it just eventually wears the immune system down, doesn't it?
Yeah, I think too, you often get people who've had poisoning of various sorts, and even following an anaesthetic, where there's really control over what that person is being given. It may well be the anaesthetic that's caused the problems, the ongoing problems, or some of the other drugs they've been given, or the actual underlying illness that they were perhaps having an anaesthetic for. I mean, I've had patients in the past who, for example, have had an ME type of illness following a tooth extraction under anaesthetic. So there's a kind of a constellation of problems often that just happen to all come together all at once, and added to which, with any illness, particularly if it's an illness that affects one's social or ability to work, there's a huge amount of stress involved.
Yeah, absolutely. So Warren, you receive a lot of communication from the ME community. Is there a common theme that people living with ME would want their health professionals to know?
Well, there absolutely is. But first, can I say that the good news is that a number of patients now that are contacting me are at least saying that they have found clinicians who affirm their illness. And this is one of the things that when I'm talking to medical students, I get a lot of very nervous medical students saying, what do I do when I see an ME/CFS patient? And I always just say, just accept the fact that they've come to see you because they're ill, affirm their illness, and that goes a long way. And that's not to say that these patients are saying their clinicians know very much about the illness, So, and I see this, like I'm constantly asked in Dunedin, from students who have come down with long COVID or ME/CFS, are the doctors they can go and see. And I have to say, there's not a long list that I can actually give them. I do know of 1 or 2 doctors who patients have told me have affirmed their illness and have reached out to them and tried to help them. So I tend to tell students about those. The critical things then we did with our quantitative survey of 160 ME/CFS patients and about 60 long COVIDs, and we asked as part of it, questions about that. And they all said they want their clinicians to have more knowledge and more understanding of the disease, but the precious quality which seems to be something most dear to them is empathy. And, you know, I've felt quite guilty when patients were first starting to contact me and ask for advice because I couldn't tell them the magic bullet that was going to cure their illness. You know, all I could do was to give them half an hour on the phone or, you know, answer with a long email. But I found that actually most people, that's the most important thing, is getting that kind of empathy and understanding, you know, and some help and some tips. And I have to say, of course, I'm aware, and I tell medical students this, you know, that we have a gold standard for how patients should be treated, and that's how Ros has managed her practice, you know, which is a management practice, a respect for people, trying things out of her toolkit, you know, that's suitable for individual patients, because of course not all patients will respond in the same way to the same thing. So, you know, I mean, I certainly, you know, have great respect for the way that Ros has managed this. And doesn't appear to be frightened of her patients like I see some, you know, clinicians in Dunedin.
Yeah, and I think it is a highly individualized illness, isn't it? And it requires an individualized treatment plan. There's no one size fits all. And I'm sure you found that over the decades, Ros. So is there specific advice you would give to GPs about how they can help their patients?
Well, I think, you know, learning how to understand and diagnose the illness so that the doctor can say to the patient, I think this is what you've got, because straight away, as soon as one's got that kind of diagnostic answer, it gives the patient an enormous amount of satisfaction. But even if the doctor doesn't feel competent about making the diagnosis, and it is a most complicated illness, there's no doubt about that, but even if the doctor doesn't feel competent, at least getting on side with the patient and saying, well, I'll work with you, we'll try and find out what's going on. If necessary, we'll involve other people. I think that empathy that Warren has just talked about is so important, and it is halfway to making headway in helping the patient understand and come to grips with their illness and explore it further, really, to get the right sort of messages across.
Absolutely, thank you. And we'll just finish up a little bit, just going back through the similarities and differences between ME and long COVID. And we're going to discuss your research in a later episode, Warren, in detail, I think. But is there something you'd like to say specifically to health professionals about the two conditions that can help inform patient care?
Well, certainly appreciate that ME/CFS is a model disease, which, you know, one can get a lot of information about to help long COVID patients. Appreciate, I think, that the diagnosis is made earlier, and that means there will be a lot of people in the transition from actually going through a later recovery phase. And so in that way, that's a unique feature. And really encouraging patients, I think, not to try to get back to their normal activities too quickly. And, you know, what I've noticed that while ME/CFS people that have had the illness for a long time, they're very much aware of this and, you know, don't try and do that. But the long COVID patients that I've had to deal with, they all want to get back to work immediately, you know, when they're not really ready to. So just taking the time for that recovery process to kick into gear, because that might actually increase the percentage of people who actually recover with, say, in a year and rather go on to have ongoing illness.
Yeah, and I think that's the tricky thing with long COVID, because particularly with Omicron, the symptoms have been so mild for a good percentage of people that they haven't really felt that ill. And then all of a sudden, when they try to get back into work and into their busy lifestyles, they're experiencing these brain fogs and wooziness and all those kinds of symptoms. And so I guess that's the message, isn't it, Ros, that pacing is the key that they can learn?
I think, yeah, pacing is a good term to use. really going at it very, very slowly and watching for symptoms, so that, you know, if you're gradually rehabilitating and you start trying, for example, as people often do, getting back into their sporting pursuits and things, and that may just be walking, if this brings on symptoms, that should be looked on as a warning sign that you're just not quite ready for this yet. And it may take a long time to rehabilitate, and coming to terms with this changed lifestyle, changed activities, and gradually sort of learning about the illness so that you don't push yourself too hard too soon. Because that would be the commonest reason why people relapse or just don't get better. They're just pushing too hard and their expectations are too great too quickly.
Well, thank you, Know M.E, to both of you. It's been descriptive discussion on classifications and symptomology. And thank you both for providing your wealth of knowledge and expertise and touching on your research as well, Warren. So thank you both.
My privilege.
Yeah, it's been very enjoyable to be involved.
You've been listening to or watching an episode of Know M.E, a place for you to hear the most up-to-date evidence-based information on ME. Thank you for joining us.